Good afternoon, everyone, and welcome to this our 99th episode, shall we say, of MRFTT STI ECHO. I am Dr. Gregory Boyce. Next to me is our director, Dr. Jeffrey Edwards, who will be joining us for our pre-World AIDS Day session of our ECHO presentation. And hi, Conrad. Thanks again for all your great support. And I hope everyone who is getting prepared for whatever activity they may have decided to engage in on World AIDS Day. And the theme this year being Find the Right Path. So let's go into something that happened a little while ago, but I think it's important for us still to touch on it in terms of what happened in the recent meeting was in July. IAS conference happened in Germany. So we're just summarize some of the key findings and just acknowledging our support from PEPFAR, ITEC, and HRSA, and as well University of New Mexico, who would have started the whole ECHO movement in the first place. So just going to outline MRF's contribution directly or indirectly to the IAS 2024. We'll talk about long-acting PrEP with lenacapavir, which is one of the more newly developed antiretroviral agents. We'll talk about something called Levi's syndrome, because that has importance as to how we diagnose persons who might have broken through while on a long-acting preparation. We'll talk about some second-line treatment trials. There's a study that was done in Haiti at Gasquio, transitioning patients to bictegravir FTC TAF. Another approach was something called a DEF trial. And we talk about another trial, somewhere in the middle of there. We'll talk about as well a second Berlin patient. Let's mention it briefly, because it's always exciting when these patients sort of appear on the landscape. And we'll also touch on abacavir and cardiovascular disease. It's been a recurring question for a long time. I think the more and more data we have on it, the better the picture with respect to what role abacavir actually plays in cardiovascular disease causation and what its future would be in terms of future therapeutics, given that we're talking about non-communicable diseases and HIV and aging and all the other things we're looking out for. And if there's any one of our medications that's contributing to that, should we reconsider use of those regimens? So with respect to the contribution of Trinidad and Tobago and MRF in particular to the IAS conference, so a three-person contingent of persons from MRF, Dr. Niall Lyons, who's a senior technical advisor, Sharon Sawyer, and our social worker, Shaman Lazama, actually went to the conference. Dr. Lyons had an oral poster presentation entitled Taking Best Practices to Scale, Implementing National Clinical and Policy Guidelines for Intimate Partner Violence in HIV Settings in Trinidad and Tobago. The full conference proceedings are actually available online now, so you can actually see the entire proceedings, download abstracts, download posters such as this, and this was essentially an implementation science track with respect to updating and identifying gaps. And I'm not going to go much in detail into this presentation. We hope at some point in time we can invite Dr. Lyons and the group to discuss the actual process for implementing this activity at a later date. And as well, the other poster presentation was a study that was done at MRF in conjunction with the Ministry of Labour and the NACC with respect to psychosocial distress of persons living with HIV in the workplace in Trinidad and Tobago. And there were a lot of really, eyebrow-raising findings in terms of the percentage of persons who had self-harming thoughts was really quite high, and as well as the number of persons who had actually experienced stigma in the workplace, and close to 1 in 3. So I would just want to recommend that you read through this and hopefully be able to have the Ministry of Labour come and talk to us about this. Is a very important issue because we're talking about persons with HIV having normal lives. We talk about a rights-based approach to the management and how we reduce stigma, and yet we're still seeing this amount of stigma affecting persons in the workplace and affecting the quality of life. So it's a very important study that was really eye-opening. So let's get down to some of the nuts and bolts of the presentation now. So this is on the prevention track, long-acting injection, pre-exposure prophylaxis with long-acting lenacapavir. So first thing, what is lenacapavir? So it's one of the newer...
Sorry, Greg, we're not seeing the slides.
Are you seeing them now?
Yes, it's coming up now. Yes, we're good.
I think the sharing that bumped off temporarily, I forgot to reshare, so sorry about that.
Okay.
So the question would be, so what is lenacapavir? It's one of the newer classes of antiretroviral agents called a capsid inhibitor. So a capsid is a protein shield around the nuclear, so the genetic material of HIV that is transmitted through the virus, through the cell wall into the nucleus, and then it's rebuilt on the outside when the virus is reassembled. So you see it acts in three different places, on entry of the virion into the cytoplasm of the cell, on entry of the nuclear material into the nucleus of the cell, and then post maturation and post extrusion and reassembly of the viral particles. So the capsid inhibitors act at those three locations. And there's an oral version and there's an injection version, but for the purpose of the study, they used the injection version of lenacapavir, which can be given every 6 months. So
Sorry, Greg, to disturb you again. If you could just make it full screen, because we're not seeing the presenter screen. So if you could make it full screen for the slideshow. Yes, that's perfect. You can unmute yourself and continue, Greg.
So you're seeing everything clearly, right?
Yeah. Yes, this is great.
Yes.
Right. So with respect to the rationale for this study in the first place, so one of the issues that we, as a sort of medical community, have identified with oral preparations of pre-exposure prophylaxis is that there's an issue with adherence over time, and we know if you don't take the tablets, the medication doesn't work. It was one of the issues early on in the pre-exposure trial history that medication, the PrEP didn't seem to work, and when they actually checked, it's because patients weren't taking the medication even though they say they were. So the idea would be, and this would have probably come out at the back of another long-acting pre-exposure drug called cabotegravir, was shown to be extremely efficacious in terms of reducing incident HIV infections. So these trials were actually done in two groups: purpose one, which was for cisgender women, and purpose two, the results of which actually came out not very long ago, which would be cisgender men, transgender women, non-binary persons who have sex with biologically male partners. So with this trial, essentially, the idea was to, with cisgender women who were given 6 monthly injections of lenacapavir versus either emtricitabine tenofovir, which is the what we're accustomed to, or emtricitabine tenofovir alafenamide, which is a newer version of tenofovir, and compare efficacy. Now, for ethical reasons, it would not be appropriate anymore to conduct a trial where you're comparing an investigational agent to placebo in a pre-exposure prophylaxis trial, because there's so many efficacious agents available to prevent HIV transmission. You shouldn't be comparing a new agent to nothing. You should be comparing a new agent to what is available already. So in the case of this study, that was what was done. And what it found was that there were no transmissions during the study period. And zero might be 0% confidence interval, right? But it was superior both to emtricitabine tenofovir, which we kind of know as Truvada, and FTC TAF, right? And as well, the study also assessed, the tolerability and adherence of the persons who took simultaneous lenacapavir versus oral yearly PrEP. Right, so this was just a quick summary. It was done, it's a randomized double-blind phase 3 trial in South Africa and Uganda, ages 16 to 25, sexually active with cisgender men, not pregnant, unknown HIV status, so no prior testing, no PrEP use in the last few months. And essentially the primary analysis was lenacapavir versus background HIV incidence, right, which is about 2.1%, if I remember correctly. FTC TAF versus and FTC TAF versus background HIV incidence to see what reduction of HIV incidence was there. And secondarily, again, and lenacapavir versus tenofovir, the effects on HIV incidence. And in terms of baseline characteristics, as you can see, the median age was 21 in all three arms. Unsurprisingly, given the geographical area, mostly a Black race, or 9 to 10% college university education, not high marriage levels, but cohabitation levels are reasonable. A fair proportion of persons with previous STIs, small amount of persons with previous PrEP use in the past, and fairly high previous HIV testing rates, so 80% across the board, right? And in median times, was 6 months since the last test. And the interim analysis, the background HIV incidence was about percent, and the lenacapavir, with the person who randomized lenacapavir arms had no transmissions during that time. What they found was that both FTC TAF and FTC tenofovir, they did not perform well in terms of reductions in HIV transmission. And a big part of that, as we'll come to, was adherence, right? That a significant proportion of the persons who were randomized to daily oral PrEP just were not taking it, right? Versus an injection every 6 months, right? So if you check the orange box on the right, there was a statistically significant reduction in HIV incidence versus background HIV incidence versus FTC TAF versus FTC tenofovir across all three arms, but there was not much difference between FTC TAF and FTC tenofovir in terms of reduction in HIV incidence. Now you can see the bottom line in the oral treatment arms, HIV incidence was no different from background and treatment adherence was poor, which further underlines, that we need to think about different ways of enacting long-term pre-exposure prophylaxis in persons who are high risk for HIV, because oral PrEP in some populations just does not work, not because of lack of efficacy, but because of poor adherence. Right? So when we're thinking about potential PrEP programs in this country, when we virtually rule it out, that's one of the things we have to think about. And when you think about adherence here, so on-time injections were above 90% on both instances, whereas adherence as measured by levels of actual tenofovir drug in plasma, the levels of persons over the year, by the end of the year, we're talking about 84% of persons in the FTC TAF arm and over 90% of persons in the FTC tenofovir arm taking fewer than 2 doses a week. And fewer than 2 doses a week is 1 or 0, right? So it's a real illustration of what the difficulties of taking daily PrEP can be for a population of persons who are otherwise highly motivated to do so. Sometimes that motivation wanes very rapidly over time. As a matter of fact, if you take a look at this chart, by the end of 8th week, 50% of persons in one arm and about fully a third of persons in the other arm, that's 2 months, right? We're taking somewhere between a half and 1/3 of daily PrEP. Now, one of the major issues that we're going to face in all over the world when it comes to access to some of these new molecules is cost. Now, the asking price, if you were to sort of in the US and so on, is $42,000 US per year, which is per patient per year, which is not affordable. And for the places that need it the most, this would just not be manageable at all. And there were protests at the conference regarding drug pricing and access and drug access and that sort of thing, very much mirroring what happened like in the early 2000s when the slogan was patients before patents. That the companies that were unwilling to share patents and to issue licenses and to keep the drug prices high, there was a global outcry with respect to, because places in the world that need these newer technologies the most are often the places that can least afford to pay, especially when they talk about 40,000 per patient per year. Right? Now, there was a study that showed that if you were to produce it generically, the cost would be somewhere between $1,400 US per patient per year, which is much closer to the reach of more treatment programs around the world. And actually, fairly recently, about the earlier part of last month, Gilead, whether it was as a result of pressure, whether that it was always the plan, because Gilead does have lots of access programs with respect to some of their compounds. They have a long track record of that. They signed voluntary licensing agreements with 6 generic manufacturers, which would increase access to this compound in high incidence resource limited countries, which is very welcome. And the UNAIDS did actually issue a statement, responding with great enthusiasm about this decision by the company. Now, one of the issues that we will have to face as well is something called long-acting early viral inhibition, or Levi syndrome. Now, if we think about persons who are taking daily pre-exposure prophylaxis, taking their medications, and let's say not taking it well or stopping it completely. Let's say you're on PrEP for 3 months, at the end of 3 months, you're not taking it as regularly as you should. The drug levels drop, you're exposed to HIV, you're not as protected as you should, and you acquire HIV infection. We expect a certain type of symptomatology when that happens. The fever, the acute HIV infection, the AHI you see, right? You may have, fever, chills, rash, sore throat, lymphadenopathy, lots of different things. And the antibody positivity is early. You get high levels of virus in plasma. And that's how we're accustomed to thinking about someone who seroconverts on pre-exposure prophylaxis. That is pretty easy to diagnose by standard methods. But with the cabotegravir trial that happened earlier, they realized because these drugs are in the person's body for so long, it blunts both the clinical manifestations as well as some of the virologic, immunologic manifestations of seroconversion. So you may not get antibody development at amounts significant to even trigger an HIV antibody test sometimes for a long time. You may not even get detectable RNA for a long time because you still have these long-acting medications in your system, not high enough to be protective, but high enough to suppress viral replication. So as you can see on the right-hand side with this Levi issue, that often the symptoms, I say, instead of explosive, they're smoldering, minimal variables, often no symptoms reported. Detection may require ultrasensitive RNA assay. Often the viral levels are low, undetectable, both and diminished antibody production. So you may actually not have be able to, if you were to do a rapid test, this person may test negative. And so one of the things that was recommended was, okay, so in persons who are on these long-acting compounds, well, just do a viral load, right? Just screen them with a viral load at the beginning and periodically in between to assess for failure of prophylaxis and viral breakthrough. But they actually did a study and those were the CDC guidelines at the time, and they actually did a study to determine, well, is that screening mechanism actually feasible, right? Would you get good results from that? Would you actually get a lot of false positives? What they actually found was that in the cases where they actually screened as per guideline, which with viral loads, that most of the persons who had positive viral loads, of 22 were false positives, right? So you did a lot of tests, you got about 20 odd positive results, but 22 of those were false. So when it was repeated again, it was found to be they were actually found to be negative. And this is important to remember that no test is foolproof, right? All tests can potentially have a small false positive, false negative failure rate. And when in settings where the prevalence of a condition is low, if you get a positive test result, it's most likely to be actually a false positive. So in this case, they actually found that doing rapid positive RNA tests actually got a lot of false positives, and sometimes it might be late treatment because you think this person is seroconverted, and it wasn't very useful. I think the positive predictive value, meaning the value of the test to show that positive test is possible, just about 18%, which is way too low, right? Which is just way too low, so it's not useful. So we may have to think about different ways in the long run, when these technologies do become available, how do we actually determine when someone has undergone failure of prophylaxis and has acquired HIV? Because we may wind up treating persons who are actually negative. So let's move on to some second-line switch studies, because one of the issues that we're starting to contend with is that with some of the newer, more potent antiretroviral agents, some of the regimens that we would have put in place with respect to empiric switches. So someone is on a regimen of A, B, and C. They have a regimen failure. We switch them to C, D, and E, well, D, E, and F, sorry, let's say, because of certain expectations with respect to activity of drugs and so on. So this was a study that was done in Haiti Gasquio centers, and what we're trying to determine. So when someone is on first-line treatment with combination of agents, and they undergo regimen failure, and they switch empirically to a second-line regimen consisting usually of a protease inhibitor, right, atazanavir or lopinavir, along with 2 nucleosides, depending on which combination they were on when they underwent first-line failure. Compare that to switching those persons to bictegravir FTC TAF, which is one of the agents that's available right now. Because the WHO guidelines would usually say if you're on emtricitabine, tenofovir, efavirenz, or emtricitabine, tenofovir, nevirapine, first line, undergo treatment failure on that, you switch to lamivudine, zidovudine, atazanavir, or lamivudine, zidovudine, lopinavir, ritonavir, right? There were some studies that were conducted earlier that actually demonstrated that no, you can actually use a different approach and achieve better results using things like dolutegravir, and in this case is to use bictegravir, which is an integrase inhibitor, single pill regimen. And despite resistance studies that might suggest that one of the components in that drug, namely tenofovir, would not be active, there have been studies, and we'll come to it later, that show that no, that approach would actually be efficacious, that you would still get comparable or superior levels of viral suppression on a single pill regimen that containing an integrase inhibitor like bictegravir or dolutegravir. All right. So in this trial, those with HIV, 18 years of age, who would have experienced first-line failure without resistance testing, and this is key, because many places around the world that are resource limited don't have access to resistance testing at all, or at least at first-line failure, right? So a lot of times we have to switch empirically. We have to use our best guess as to what would be the best second-line regimen to use, or follow the WHO guidelines, which I cited previously. So they would be on second-line treatment for at least 6 months with either atazanavir, ritonavir, or lopinavir, ritonavir, and 2 nucleosides, with an HIV RNA of less than 200 copies for at least a year. So these are persons who are on treatment and doing reasonably well for at least a year, and who didn't have any evidence of renal impairment, hepatic injury, and no previous history of integrase exposure that might affect the activity of drugs like other integrases like bictegravir in the future, right? So the primary outcome was a proportion of persons who had HIV RNAs greater than 200 copies at week 48, and other things like tolerability, weight gain, lipid changes, and adherence. Because some of these regimens, like for example, lamivudine, zidovudine, lopinavir, ritonavir, are 6 pills a day, right? 3 by 3. Sometimes there are a lot of gastrointestinal side effects versus 1 pill a day, right? So sometimes it may not be how efficacious the regimen is, but if it's simple to take and fewer side effects, you may find better outcomes because patient is able to take it without having to worry about large pill burdens or awful side effects. And at week 48, in terms of virologic outcomes, what essentially they found is that switching to bacterial FEC TAF was as good as remaining on the previous regimen with the protease inhibitor, whether that is atazanavir or ritonavir. All right. And there was no difference in adherence between groups, which is encouraging. In terms of tolerability and adverse effects, there were no great changes except in the bictegravir group. So there were some lipid profiles that were significantly better in bictegravir versus some of the other protease inhibitors that can sometimes affect lipids. But there was no difference in total cholesterol HDL ratios, which can sometimes be a marker for cardiovascular disease in the future. And I just want to reference, this was actually part of an ECHO presentation that we did about a year ago. We spoke about the Nadia trial, which essentially sort of was the same sort of thing. So WHO guidelines give certain recommendations with respect to how you manage first-line regimen failure, which drugs you use when, based on what drugs you were on when you underwent regimen failure. But what they actually found when they did this study, they would have randomized persons who were on the failing regimen to emtricitabine, tenofovir, dolutegravir, lamivudine, zidovudine, dolutegravir, or emtricitabine, tenofovir, darunavir, lamivudine, zidovudine, darunavir. What they found was even in persons who were shown to have drug mutations that would make tenofovir less active, or where you would expect tenofovir to not be active at all, that you still had good levels of viral suppression. As a matter of fact, you had better viral suppression on lamivudine, tenofovir versus lamivudine, zidovudine when paired with darunavir, ritonavir, which kind of turns a lot of what we thought about medication and drug resistance on its head, because it means that we have to rethink how HIV undergoes suppression when there are mutations to the nucleoside backbone if it's paired with a highly potent agent like darunavir or dolutegravir. So this is another similar trial called the DEFT trial, right? So same to the background rationale that there's limited data on the safety and efficacy of second-line regimens of a treatment failure when first line is non-nucleoside based, meaning efavirenz-nevirapine, which is about 80% of our clinical population at MRF right now. In 2017, the standard of care was for ritonavir boosted protease inhibitor, so atazanavir or ritonavir, usually less often darunavir in most places, and 2 nucleosides often recycle, as I said before. Current guidelines also recommend dolutegravir and 2 recycled nucleosides, but in persons who would have undergone first-line failure with NRTI-based ART, the DEFT trial compared 2 dolutegravir-based second-line regimens versus standard of care with darunavir, ritonavir, and nucleoside. What essentially showed at week 48 was that darunavir, ritonavir plus dolutegravir and nothing else, right? So it's an NRTI-sparing regimen, and dolutegravir, lamivudine, or tenofovir plus tenofovir were non-inferior to the previous regimen. So either forgetting nucleosides entirely, just have dolutegravir and darunavir, ritonavir, 2 very highly potent agents against HIV, or tenofovir with either lamivudine or emtricitabine plus dolutegravir, right? Which would not exactly be what the guidelines would suggest. They suggest that, you know, if you're on, if you feel not enough based regimen, should go to zinobidine. But it's keeping the tenofovir going, one, which is a single pill tablet, and along with dolutegravir, which actually could be a single pill regimen, that you're able to maintain levels of viral suppression. As a matter of fact, what they found was that dolutegravir plus dolutegravir tonabacort was actually superior to standard of care. In other words, forgetting the nucleoside backbone entirely, leave that argument out, and just giving dolutegravir plus dolutegravir tonabacort was superior to standard of care. So in the IAS study, they would have presented the 96-week data, and this is again the design of the study. It's an international open label non-inferiority phase 3b/4 trial that's in persons who would have failed a nucleoside, non-nucleoside based regimen with no previous exposure to proteases or integrase inhibitors and other inclusion criteria seen on the left. That they randomized either to
First, what?
regimen.
I said people great. So kind of way after.
Go ahead, Dr. Boyce.
Right. So either you a nucleoside sparing regimen with dolutegravir and dolutegravir tonabacort, or standard of care, right, with dolutegravir tonabacort, 2 nucleosides, or at a later stage 2 level, stage 2 randomization, you would have PDC or FTC plus tenofovir plus dolutegravir, and at 96 weeks, you can see the study population was, you know, similar BMI, male female was you know, mostly roughly 50-50, but slightly more males and females in some, slightly more females and males in the other. But you can see with a lot of these patients, they see CD4 counts are in quite a few of the arms, it's less than 200. These are persons with fairly advanced disease, you know, with viral loads over 10,000. And the median duration of ART for most of these is 4+ into 5 years on medication. These are persons who would have been in care for quite some time. Right. And as you can see at week 96, you're still seeing that for the dolutegravir tonabacort arms, whether it's at the -50, so under 50 RNA level, on a 200, on a 400, the dolutegravir with dolutegravir tonabacort is statistically significantly superior to what would be considered standard of care. And also the arm with tenofovir, lamivudine, or emtricitabine plus dolutegravir was also superior to standard of care, which again turns it a little bit on our head. But in a sense, it's comforting, because one of the major issues that we sometimes face when we don't have access to resistance testing as well, we could either put persons on a lot of medications all at once and hope for the best. So for example, in someone who may be having regimen failure after first line treatment, and we don't know what the mutation profile looks like, sometimes we may overtreat because in an attempt to ensure that we don't wind up undertreating and causing the person to experience more resistance and more breakthrough. But this suggests that with either potentially 1 or 2 pills a day, we can achieve similar levels of viral suppression to a more complicated regimen. The one of the issues that they did also check was median change in weight, and as we knew from some of the earlier studies, that integrase-containing regimens sometimes and often, especially with some other things like tenofovir, can cause more weight gain. So in the dolutegravir containing arm, there was in both dolutegravir containing arms, there was statistically significant increase in weight, and also statistically significant increase in CD4 count, because you also that integrase inhibitors tend to cause a rapid increases in CD4 counts over time. So the investigators' conclusions were that a second-line treatment after non-nucleoside-based treatment failure, both dolutegravir, dolutegravir, and dolutegravir, tenofovir with either 3DC or FTC was superior to standard of care in achieving virologic suppression and immunologic recovery through 96 weeks. And they found that in a second-line regimen that contains tenofovir, dolutegravir, and either 3DC or FTC without resistance testing, that you still got good efficacy from that regimen. And all treatment combinations are well tolerated and few switches due to toxicity. But both dolutegravir-containing regimens were associated with greater weight gain than dolutegravir, so darunavir, tonavir, and two nucleosides. So that may be something that we need to look at long-term when we think about weight gain over time and risk for cardiometabolic complications. And this, so this was sort of the final study in this class, which was a similar study where on first-line regimen failure, they would have randomized persons to either a dolutegravir-containing regimen with lamivudine, tenofovir, or FTC TAF versus a protease inhibitor-based regimen with lamivudine, dolutegravir, and the tonavir, tonavir, or atazanavir, tonavir. This is per WHO guideline, right? And they found essentially that the dolutegravir-containing regimens were not inferior to the combined protease inhibitor arm. So essentially, the WHO guidelines that would have suggested that in someone failing a tenofovir-containing regimen that you switch to lamivudine, dolutegravir, and a protease inhibitor, you could switch to single pill lamivudine or emtricitabine, tenofovir, dolutegravir, and achieve similar results. So we'll speak just briefly about the REPRIEVE trial and a sub-analysis of the REPRIEVE trial. So what was the REPRIEVE trial? Essentially, it was a multi-center double-blind study of persons living with HIV enrolled over a 4 to 5 year period who were on ART stable with decent CD4 counts, but who were at a low to moderate risk of cardiovascular disease. So these are persons who we would not think about starting on a cholesterol-lowering regimen because their risk is low, because that's how we think about using a statin, right? If someone has a significant risk of cardiovascular disease over the next 10 years or 5 years, then we would introduce lipid-lowering drugs to reduce that risk based on certain criteria, based on certain risk calculations that are heavily based around some of these cholesterol numbers, your LDL, HDL, total cholesterol, and so on. So we know that HIV in and of itself is associated with a higher risk of cardiovascular disease, independent of any other risk factor of cardiovascular disease. So this study was essentially trying to show, well, in persons who, given that we know that HIV is the independent risk factor for cardiovascular disease, should we be targeting persons differently when it comes to initiation of a statin? So in persons with low to moderate risk, they were started a particular statin called pitavastatin. And throughout this study, they actually found that there was a 36% reduction, which is very significant, right, in major adverse cardiovascular events, so including heart attack, strokes, peripheral artery disease, or cardiovascular death in pitavastatin versus placebo. So that essentially suggested that we need to lower the threshold at which we consider starting statin as a person with HIV, even though the cholesterol levels look pretty okay, that we need to start at an earlier level. I think the British guidelines are starting to change to suggest that. I believe the American guidelines already have. Part of the cardiovascular disease question has been for quite some time, what is the role of abacavir? And this is going back to a really, really long time now, with some of the early DNA cohorts and so forth, where it was shown that, or suggested that abacavir was independently associated with an increased risk of cardiovascular disease. So this has been a recurring question for years and years. Is this a real thing? Is it not a real thing? Is this because of a system of selection bias? Is it not? So as part of this trial, it was powered to to assess differences in cardiovascular outcomes, it is some analysis of persons who were prescribed abacavir who had previous history of exposure to abacavir, right? And in this subpopulation, 22% had a previous history of abacavir exposure, so 9% former use, and 50% were on abacavir at randomization. And they actually found that the risk score, so if you had previous abacavir exposure, there was a 5-fold increased risk of ASCVD events. If there was no abacavir exposure, 4.2, and the total population was at 4.5 increased risk. So essentially, current and former abacavir use was associated with, between a 42 to 50% higher risk of a subsequent adverse cardiovascular event, which was not affected by exposure to any other group of antiretrovirals, whether it's integrases, non-nucleosides, or proteases. And current and former use of other antiretroviral agents, such as tenofovir, protease inhibitors, some of which have actually been implicated in cardiovascular events, and thymidine analogs with some of the older drugs like zidovudine, didanicine, and stavudine, were not associated with subsequent cardiovascular events. So it seems that this sub-analysis does add more and more evidence in support of the fact that abacavir does bring with it a high risk of cardiovascular events over time, and it may be something we need to maybe consider moving away from. Right now, the primary population of persons who are on abacavir are persons with advanced renal impairment who cannot use tenofovir as part of their nucleoside backbone. Some of the newer combinations that were suggested, some of the earlier second line trials might suggest that we may be able to employ in persons who can't use a tenofovir-containing regimen, and in whom we would not want to use zidovudine-containing regimen because we're moving away from zidovudine over time, that we may be able to use a nucleoside-sparing regimen, like, for example, a dolutegravir, darunavir, ritonavir regimen, and achieve just as good levels of viral suppression without having to worry about, cardiovascular events as a result of abacavir. And so this, I think, we've got just a couple more slides. I think this is the second to last one. So this was our second bullying patient. So the history is very similar to some of the previous, a lot of the previous persons who were cured of HIV. This is someone who was living with HIV, diagnosed, quite a while ago, about 15 years ago. Was diagnosed with, leukemia, required a bone marrow transplant. Now, this person happened to have a gene that, what they call the del32 mutation, that CCR5 del32 mutation. So they were missing one of the genes that would code for this CCR5 co-receptor that HIV requires to enter cells, and they got a bone marrow transplant with somebody else who was also missing one of the genes. Not what they call a homozygous, missing both genes or missing one of the genes, but they were found that after they received bone marrow transplant, that they stopped ART subsequently. They've been in remission for 5 years. So I think this is now sort of a well-trialed way to get some persons who are living with HIV and who require bone marrow transplantation. It is a strategy that seems to work. The problem is it's not scalable. I mean, I include it here for interest, but it's not something that can inform, broad-based approaches with respect to cure of HIV. But it does keep adding a little bit of information, because previously when patients which had bone marrow transplantation from bone marrow donors who were heterozygous for the mutation, it wasn't successful long term. I think this was the first person who actually received a bone marrow transplant for someone who was heterozygous for the del32 mutation, but the patient was also heterozygous, and that may have had something to do with it as well. So again, it's interesting, but it doesn't inform practice very much, unfortunately. So just a final note, this is a couple of days before World AIDS Day. Take the right path to end HIV and AIDS. So just want to put a plug. We are partnering with the Rape Crisis Society of Trinidad and Tobago and persons from Medical Research Foundation, staff at the Medical Research Foundation will be supporting them at the candlelight vigil. You can go to their website or their Instagram or social media posts and see what we're about. Wear something red. I've got my red shirt, and we're going to support this important cause. And I want to encourage everyone to do something. It doesn't have to be that thing. It doesn't have to be the specific issue that MRF is supporting, but support someone living with HIV and do something to make a difference. Because as the study that the Minister of Labour did, there's still a lot of persons who are undergoing lots of stigma, still a lot of persons who are concerned about their rights and their privacy being trampled upon. So we need as a society support our brothers and sisters who live with HIV. So whatever you do, every little bit helps. And I think that's the end of my presentation for today. And again, I thank you for your attention.
Thanks so much, Greg. I think I'm jumping straight in with comments and questions. I think the one thing that really kind of stood out for me is how positive it seems for persons who might be transitioning from whatever medication they are now to maybe some of these newer types of medications that we might be seeing coming out in the future. I wonder if you could just summarize something just on that first.
Oh, so one of the, I guess, advantages that we had at MRF for a long time was that we had access to resistance testing. So in someone who is on their first-line regimen and they're undergoing treatment failure, we had the ability to take a resistance test, send it to Puerto Rico, get a result back, so we know exactly what to put them on. Right? So a lot of our first-line switches were guided by resistance testing, right? And at the time, and still at present, a lot of the combination that we would use would be things like lopinavir, which is 4 pills a day, and azanavirtol, where thankfully it's still 1 pill a day. But there are some issues with respect to drug interactions and so on, and pill burden and pill size. And sometimes you would have to switch persons. You see a certain mutation that says, well, you must be on this tablet. This tablet is 2 pills a day. Side effect profile is not the best, but it's the only active drug that we have available to, because this mutation that we developed because of development of drug resistance to regimen means you have to use this drug and nothing else, because that's what the resistance test says, right? What some of these studies demonstrated was that we do not fully understand how these mutations really affect activity when there's the second drug, the anchor drug, is a potent anchor drug like dronabinol, ritonavir, dolutegravir, or even bictegravir, right? So let's take the case of tenofovir, right? I will use the trade name because a lot of people don't understand that way. So atripla, emtricitabine, tenofovir, favipiravir. 80% of our clientele is on atripla, emtricitabine, tenofovir, favipiravir. When persons undergo treatment failure on this particular regimen, very often they develop a mutation called K65 mutation, K65R, that based on our previous knowledge tells us that tenofovir will not work anymore. High level resistance to tenofovir, it's done, it's gone. So you have to now put if you're using the drugs in nucleoside class still, like tenofovir, like lamivudine, like emtricitabine, you have to use zidovudine. You have to. It's the only thing that's effective. Because that's what the resistance test says, that's what all the lab tests say. Right? You get good activity with zidovudine. What these new trials are showing, and that's the DEF trial, the Bison, Nadia, the study in Gescu, is that, well, actually, no. With some of the newer agents like bictegravir, like dolutegravir, dronabinol is no longer new, but it's highly potent, that you can keep the tenofovir going, right? Keep the emtricitabine going, even though the resistance test says they're not supposed to work, but you keep them going, and you still will achieve comparable rates of viral suppression to if you switch based on the WHO guidelines, even if you switch based on resistance testing, that tells you that you have to switch from tenofovir to zidovudine because you have this mutation that wipes tenofovir out. These study results are directly challenging those assumptions that we had for a very long time, right? Which is fortunate because zidovudine is an old that's been around for a long time. It can sometimes have a not so good side effect profile. It's, one pill every 12 hours versus keeping this tenofovir going, which is still one pill a day. And sometimes in the case of, for example, dolutegravir, your second line regimen is still a one pill a day regimen. So your MC tenofovir fibril is one pill a day. We switch to another one pill a day. Essentially, we swap. We got one drug for another. It's still on a one pill a day regimen. Or if it's FTC TAF bictegravir, still one pill a day. If we're using dronabinol, ritonavir, either dolutegravir, dronabinol, ritonavir can be 2 pills once a day because there's a once daily formulation of dronabinol, ritonavir in persons who have never been on protease inhibitors before or who have no significant resistance to dronabinol, ritonavir. Or still the same one pill a day regimen. That is, I think, helpful in the long run because it gives us the evidence base that will support, simpler second line options, right? Because as a lot of us who are involved in HIV care can attest, and I see Ingrid's on the call, so she knows better than almost everybody, having been in the pharmacy for all this time. It gives somebody their drugs, and sometimes it's 8 pills a day, 10 pills a day, because based on their resistance profile on paper, that's what's supposed to work. But these studies are showing, well, you know what? Those 8 pills can be replaced by 1 or maybe 2, right? And that gets us a lot closer to getting regimens that are as acceptable as possible, low side effect, low pill burden, because we're asking persons to take these pills for a long time. And that's one of the major issues that we have with respect to adherence and achieving viral suppression and achieving eradication of HIV and AIDS as a public health issue. We have to get the regimens to a point where persons can take them, right? And some of the older knowledge that we thought we knew is being actually uprooted by some of these newer trials. And that's actually very comforting.
Thank you for that, Dr. Boyce. I see Alana has a hand up. Alana, you want to go ahead?
Thanks, Dr. Boyce, for bringing that information to us. I think you started answering one of my questions, which was the limits we have for the drugs that we can use because you only have a set amount and type in the country. I was going to ask you, how do you navigate when a patient requires a change? But then you started answering it. And then, of course, the new information coming on stream indicates that what you have, you can work with. So the second question was, this information that comes out of scientific findings and trials, etc., who is the information shared with? Does it stay with any medical fraternity? Does it do the pharmaceutical companies take note? Is it shared with them and they take note, and that's how new drugs are developed or new regimens? Or does it get carried all the way to, let's say, ministries and government officials who have to make decisions about, what drugs they can, yeah.
So, for example, the entire proceedings of the IAS 2024 are available online. You can see the presentations, the plenaries, you can download posters, the entire abstract book is available. So IAS has been really good at making this stuff available for patients, for policymakers, for clinicians. It's there, right? And it's easily available. So sometimes the issue is not access so much, but using the information as an advocacy tool for changing policy, right? So because as you well know, if in a country like ours, where we know the budget is limited when it comes to antiretroviral drugs, and there have been so many, and sometimes, for example, after we got access to Atripla, right, there was nothing for a long time. So piperines and all these other drugs came and new drugs. And you're wondering, well, all patients are asking, when are we going to get this drug? When are we going to get JAK drug? But the question is, what is the incremental benefit to getting that drug? Because it's going to be more expensive. It's another complication to the formulary. Is it going to do significantly better than standard of care right now? And for a lot of those drugs, the answer was no. Right? So there wasn't, other than the nicety of having it available, it's not going to do much better by some of our clients, right? Even though it's always good to have more options, because we're talking about individualizing care. And that single pill regimen with efavirenz doesn't work for everybody. And if the next alternative is 5 pills, there have been persons who have fallen out of care because it wasn't a better option, right? So when these trials are done and they release the information, and you can see that, look, it's as good as or better, right? And the tolerability is better, and the cost is comparable. But then we can take that information and say, okay, let's take this to the policyholders and say, okay, I can make a case for why I need this drug for these classes. It's not about, the doctors want a shiny new toy to play with, right? A nice, unpronounceable drug, right? I can show a direct link between access to these drugs and better patient outcomes and lower costs in the long run. Because the more persons you keep in care and suppress, the less acute care you're going to have to. I mean, if you talk just from simple policy and simple dollars and cents, you keep persons well, keep them healthy, keep them suppressed, keep them out of hospitals. That is the best model, right? Because everything else is more expensive. Everything else is more expensive. And sometimes that's the kind of argument you have to make, because there are so many pressures on that small bucket of healthcare dollars that if you're telling someone, look, we have to make a change in how we approach treatment and care, this is why it's going to work. It's going to result in better patient outcomes without having to spend $40,000 a month, right?
Thank you.
Thank you so much, Dr. Boyce. I don't know if we have any other questions. I don't see any more in the chat, but let's just kind of open it up to persons if anyone else has a question. It's 2 minutes past the hour, so I know we've gone a little beyond time. Does anyone else have a question before we sign off? No? So our next ECHO session is going to be on January the 31st. We kind of welcome in this new series fully on January the 31st, which is a Friday as well. And so we welcome all of you all to join us then. We're going to keep you updated with what the topic is going to be via email and via WhatsApp, as we have done. And we're going to be sharing the recording from today's session in just a short while. Dr. Boyce, let me hand it over to you to do final goodbyes and any other last comments.
Oh, I think that's more or less goodbye from us. I think so. As I said before, Sunday is World AIDS Day. I'm not sure many people are going to listen to the recording of this offline, but if you do before Sunday, actually come out and support. Right? We need that groundswell of advocacy, right, from all quarters to really get things moving. And I think sometimes that's one of the areas we could do a little bit better in Trinidad. So let's get out and support our people, right?
Awesome.
Whatever.
Thank you so much. See you all again. And
Thank
we
you.
won't see you before that time. Merry Christmas, everyone.
Yes, Merry Christmas. Bye.